Hi everyone. Today, I'm going to present the topic of prediabetes and type 2 diabetes mellitus. This training modules is prepared by FMS from PKD Petaling. The first topic is prediabetes. Prediabetes is a condition where blood sugar levels are higher than normal, but not high enough to be considered type 2 diabetes. Individuals with prediabetes are at risk of progression to frank diabetes. Prediabetes can be prevented or delayed from turning into type 2 diabetes mellitus by proven lifestyle changes. Patient with impaired fasting glucose and/or impaired glucose tolerance is considered to have prediabetes. Impaired fasting glucose if the result OGTT at 0 hour is in between 6.1 to 6.9 millimoles per liter. Impaired glucose tolerance is if the 2-hour plasma glucose values of 7.8 to 11 millimoles per liter. HbA1c of 5.7 to 6.2% are considered as having prediabetes. A repeat HbA1c should be done 4 weeks after the first positive test for asymptomatic patients if an accompanying fasting plasma glucose or random plasma glucose is indeterminate. For symptomatic patients, a single positive test is sufficient. Why is it important to identify and manage prediabetes? This is because prediabetes increases the risk of progression to type 2 diabetes mellitus. Progression to diabetes can be delayed. Patients have higher CVD risk. Patients often have other modifiable CV risk factors: hypertension, dyslipidemia, and both of these diseases associated with increased CV risk. Interventions to reduce conversion of impaired fasting glucose and impaired glucose tolerance to type 2 DM are through lifestyle modifications and pharmacotherapy. Lifestyle modifications. Diet and moderate intensity physical activity remain the mainstay of therapy. There is strong evidence that combination of diet plus physical activity reduces or delays the incidence of type 2 diabetes mellitus in prediabetes, particularly IGT patients. Intensive behavioral lifestyle intervention program modeled on diabetes prevention program should be advocated for all prediabetic patients to achieve moderate intensity physical activity such as brisk walking, cycling, gardening, moderate houseworks and others for at least one 50-minute week and target weight loss at least 7%. Duration of exercise should be increased to greater than or equal to 60 minutes per day, that is approximately 450 minutes per week in overweight or obese patients to facilitate weight reduction. Diet. Based on intervention trials, Mediterranean, low-calorie, low-fat eating plans may be beneficial for prediabetes with an emphasis on high dietary fiber, whole grains, legumes, nuts, fruits and vegetables and minimal refined and processed foods. Intervention that use technology to disseminate diet and exercise lifestyle programs have been shown to be effective in weight reduction and improves glycemic levels in patients with prediabetes and should be considered as part of type 2 DM prevention strategy. There is limited evidence on benefit of bariatric surgery on reduction of progression to type 2 DM. Advised patient to take their meal based on Malaysian healthy plate with quarter plate of rice, noodles, bread or other carbohydrate sources, quarter plate of fish, meats, nuts or other protein sources and half plate of fruits and vegetables. In addition to lifestyle intervention, Metformin should be considered for those at very high risk. These includes those with combined IFG and IGT, IGT plus obesity, BMI greater than 35 kg per square meter, IGT plus less than 60 years old, FPG greater than 6.1 millimoles per liter, HbA1c greater than 6%, previous history of GDM, or for those who failed lifestyle therapy after 6 months. Metformin reduces progression from prediabetes to type 2 DM by 30% with persistent benefit, especially in women with previous history of GDM with overall reduction 18% over the 10 years of DPP or DPPOS program. Metformin is the only drug that has received endorsement by our Malaysian regulatory authority as well as other national guidelines as for the prevention of type 2DM. There are other pharmacological agents that may prevent or delay the development of type 2DM like liraglutide, AGI, pioglitazone and orlistat. There is no firm evidence that DPP-4 inhibitor and SGLT2 inhibitor compared with placebo substantially influences rate of progression to type 2 diabetes mellitus. Recommendations for prevention of type 2 diabetes mellitus. 1. The mainstay of diabetes prevention is intensive behavioral lifestyle intervention program to achieve target weight loss at least 7%. 2. Metformin should be considered in those at very high risk, prediabetes, previous history of GDM or for those failed lifestyle therapy after 6 months. In the subsequent slides, I will talk about type 2DM. I will touch on Introduction to type 2DM, Pathophysiology, Screening, Confirmatory test. Plasma glucose abnormalities may represent a progressive continuum, ranging from prediabetes, consisting of impaired plasma glycemia, impaired glucose tolerance, to overt diabetes mellitus. Type 2 diabetes mellitus is the most common form of diabetes mellitus, accounting for greater than 90% of all cases of adult-onset diabetes mellitus in Malaysia. Both prediabetes and diabetes commonly coexist with other NCD diseases, namely hypertension, dyslipidemia, and obesity. Type 2 diabetes mellitus is an important risk factor for cardiovascular disease and microvascular complications such as nephropathy, retinopathy, and neuropathy. Other non-vascular complications include infective complications. Pathophysiology of type 2 diabetes mellitus. Type 2 diabetes mellitus is characterized by progressive decline in beta cell function, associated with insulin resistance in muscle and adipose tissue. With the presence of insulin resistance, there will be increased in hepatic glucose output, and reduced utilization of glucose, by organs that will lead to fasting hyperglycemia, and between-meal hyperglycemia. There is impaired in intestinal incretin secretion that may compromise meal-related insulin secretion and glucagon suppression. These will lead to postprandial hyperglycemia. The other cause is due to excessive renal tubular reabsorption of glucose, that may lead to hyperglycemia. Screening. The risk-based screening for prediabetes and diabetes in adults should be performed in individuals greater than 30 years of age and repeated annually. In symptomatic individuals, one abnormal result, either plasma glucose or HbA1c, is accepted as diagnosis. While in asymptomatic individuals, two abnormal test results from the same sample, e.g. plasma glucose and HbA1c, or from two separate test samples are accepted for diagnosis. It is recommended for criteria-based screening of adolescents who are overweight and have additional risk factors for type 2 diabetes mellitus. Screening. The objective of screening is to detect and diagnose prediabetes and type 2 diabetes mellitus among general population, specifically the high-risk individual, whilst ensuring timely appropriate intervention. Who should be screened? 1. Symptomatic individuals. Any individual who has symptoms suggestive of diabetes that presented with fatigue, lethargy, polyuria, nocturia, polydipsia, polyphagia, weight loss, pruritus, or vulvobalanitis should be investigated to confirm diagnosis of type 2 diabetes mellitus. From NHMS data, 48.6% individuals with diabetes were undiagnosed at time of screening. Recognizing that up to 50% of individuals with diabetes are asymptomatic, makes the case for screening when specific risk factors are present. Testing should be considered when specific risk factors are present. This table shows the criteria for testing for type 2DM or prediabetes in asymptomatic adults. Testing for diabetes should be offered for 1. Women with history of GDM. 2. All individuals with prediabetes. 3. Adults who are overweight or obese, that is BMI greater than or equal to 23 or waist circumference greater than or equal to 80 cm for women and greater than or equal to 90 cm for men with ANY of the following. History of CVD. First-degree relatives with type 2DM. Hypertension. HDLC less than 0.9 millimoles per liter or TG greater than 2.8 millimoles per liter. Women who have delivered a baby weighing greater than or equal to 4 kilograms. Those who are born from mothers of GDM. Other endocrine condition associated with insulin resistance, e.g. PCOS, Cushing's syndrome. Physical inactivity and sedentary lifestyle. Those receiving long-term treatment with any following medications. Corticosteroid, heart, atypical antipsychotic drugs, thiazide diuretics, biadrenergic blockers and statin. Criteria for testing for type 2 diabetes mellitus in adolescents. Screening should be performed in adolescents who are overweight or obese or who have one or more additional factors such as 1. Maternal history of diabetes or GDM during child's gestation. 2. Family history of type 2 diabetes mellitus in a first-degree relative. 3. Recurrent abscess and/or pruritus genitalia. 4. Signs of insulin resistance or condition associated with insulin resistance, e.g. dyslipidemia, hypertension, PCOS, acanthosis nigricans, or small for gestation age birth weight. If the tests are normal, repeat screening at a minimum of 3-year intervals, or more frequent if BMI is increasing. Screening test. In circumstances where facilities for venous plasma glucose measurements are not readily available, preliminary screening can be performed by measuring capillary plasma glucose using standard glucometers. This test can be done irrespective of timing of prior meals. If the random plasma glucose greater than or equal to 7.8 millimoles per liter or fasting greater than or equal to 5.6 millimoles per liter, a confirmatory test needs to be performed by one of the following methods. Fasting plasma glucose. Oral glucose tolerance test. HbA1c. Confirmatory test. Fasting plasma glucose. This should be performed following minimum of an 8-hour overnight fast. Patient is considered to have prediabetes or IFG, if fasting plasma glucose is between 6.1 to 6.9 millimoles per liter, and diabetes if the fasting plasma glucose is greater than or equal to 7.0 millimoles per liter. Second confirmatory test is oral glucose tolerance test, OGTT. It is done in the fasting state using 75 g of glucose. Patient should rest throughout the test and only allowed to drink plain water. A 2-hour plasma glucose greater than or equal to 11.1 millimoles per liter confirms the diagnosis of diabetes. Patient is considered to have prediabetes or IGT if 2-hour plasma glucose level is between 7.8 to 11.1 millimoles per liter. The third confirmatory test is HbA1c. It reflects the average plasma glucose level over the preceding 3 months. Using HbA1c to diagnose is convenient, as it does not require the individual to fast or consume oral glucose, and it can be performed at any time of the day. The interpretations are: normal, if HbA1c reading is less than 5.7%, prediabetes, if the result is 5.7 to less than 6.4%, and type 2 diabetes mellitus if the reading is more or equal to 6.3%. This is a flowchart for screening for symptomatic individual. A single abnormal venous plasma glucose value or one abnormal HbA1c is sufficient to make a diagnosis of type 2 diabetes mellitus. This slide shows a screening of asymptomatic individuals. Diagnosis of type 2 diabetes mellitus is made when there are 2 abnormal venous plasma glucose on separate occasions, or 1 abnormal venous plasma glucose plus 1 abnormal HbA1c from the same sample values. The recommendation for screening and diagnosis are: 1. Screening for diabetes using fasting plasma glucose, or HbA1c, should be performed annually in those with risk factors and those greater than or equal to 30 years. 2. Diagnosis of type 2 diabetes mellitus and prediabetes can be made using fasting plasma glucose or random plasma glucose, OGTT, or HbA1c. 3. In individuals with fasting plasma glucose of greater than or equal to 6.1 to 6.9 millimoles per liter or HbA1c between 5.7% to 6.2%, further testing with a 75g OGTT should be considered in order to categorize them into individuals with IGT or T2DM. 4. Patient diagnosed with T2DM should have other CVD risk factors treated aggressively with close monitoring.